Yeah, Jake's tried one of my pickled eggs, and he survived.
Yeah, I mean they were all right. I've had better, but they were good.
It's definitely a flavor palette, an interesting flavor palette.
I mean, they
like
taste good sometimes. They're really good. Sometimes.
Like when I was in Wisconsin, or no, when I was in Minnesota, I had all the pickled herrings and stuff, and I was like, okay, that's different. That's different.
Man, I really liked Wisconsin cheese curds, but I didn't try a pickled herring when I drove through Minnesota.
Yeah, that's some Viking food, isn't it? Pickled fish.
For sure. But I do miss being able to have good access to cheese curds from when I was over there, because like it's hard to get them, even though we have so many dairy farms here. It's still hard to get good cheese curds for whatever reason.
Yeah, it's just it's a way of life over there.
Okay, I think we have almost everyone here, and I want to get you through this as quickly as possible so you can go on to other things. So let's start this. Okay, first of all, can everyone hear me okay? Give me a thumbs up. Okay, good. And on your screen, you can see histology guide. Okay, good. So let's go through this. Okay, this is just a low power shot of a section of thyroid gland. And you can see it has these fibrous septae kind of divided into lobules. It's very reminiscent of any type of exocrine gland, including like the pancreas, kind of looks like this. However, when you go to much higher magnification, let's give the website a chance to bring it up here. Okay, you can see all these pink dots, and that's the colloid within the follicles. Of course, the colloid contains thyroglobulin, and the main thing is they're surrounded by these follicular thyroid cells. These cells are all joined together with tight junctions, and therefore this colloid material is outside of the cell. And when you look at the follicular cells, especially on electron micrographs, you always have to be aware of what's facing the colloid, that's the apical side, versus what side of the cell is facing the interstitium or the basal side here. There's a lot of things going in and out, and we need to know what side of the fence we're on. At this magnification, we can see this colloid is interesting that it has these bubbles around the periphery. And the thinking is this represents the colloid cells drinking or bringing in pinocytosis of the colloid type material into the cytoplasm so they can go ahead and digest it and release the thyroid hormone into the bloodstream. Please notice again that as a thyroid, as an endocrine gland, there are no ducts. There are no ducts to collect secretions. All the secretions made are diffused out or placed into the bloodstream. And let's find not sure if we can always see it in every section, but there's a very rich vascular supply between each of the follicles here. Okay, that's very characteristic of an endocrine gland. Someone asked me, do you see parathyroid glands in here? And most sections of thyroid will not have the parathyroids. The parathyroid glands are very small. They're on the posterior surface. And just to give you a hint, the parathyroid gland, each one is less than the size of a penny, probably about half the size of a penny, to give you an idea. And again, we have 4 of them. If you do happen to get a section that does include the parathyroid gland, it's usually on the outside, and the parathyroid gland is always well circumscribed with fibrous tissue. So it's very distinctly different. And we'll also go over the histology of the parathyroid gland. Not so much because when we're talking about Parathyroid Friday, we'll talk about that in an ILS on a week from today, but it's just in the same anatomic location. Any burning questions about the thyroid gland? You know, the histology is pretty straightforward. Okay, so let's go on to the next one, the parathyroid gland. It's kind of deceiving because both sections are about the same size, but actually the parathyroid glands are very small, very small. In the cadaver, they're very hard to find. In an autopsy, they're very hard to find. I'm not sure how, but ENT surgeons know where to find them. They must have some secret they're not sharing with me. But they're very small. They can be confused with a lymph node or even a lobule of fat. But the really good ENT surgeons can pick them out pretty quickly. The main thing at this low magnification is to see that there are lots of clear spaces scattered about the parathyroid. Probably in this case, about 25% of the volume are fat cells. And that's a good indication this is a normal parathyroid gland. They have fat intermixed. If this was a neoplastic parathyroid gland, it would have no fat in it. All the fat would have been displaced by neoplastic cells. Okay. Now, I haven't thought of a good analogy, but the principal or chief cells, or all these cells here, they're the parathyroid cells that actually produce parathyroid hormone, or PTH. These are the active cells. They can be recognized. They have fairly round nuclei. They're very regular. They're almost equal in size. The chromatin is sort of even. It's not really super dark. And the cytoplasm tends to be cleared out or very light staining. And they're somewhat equally spaced here. I've always been trying to think of what this looks like. Maybe it looks like a bin full of ball bearings or something. But there's just a little bit of space separating these round nuclei, and it's pretty even. And again, notice the fat here. When you see fat intermixed, that's more than likely a normal parathyroid. Now I'm going to go over here. And now there's a different population of cells in the parathyroid, and sometimes they're hard to find, sometimes they're very easy. They tend to form these large clumps. These are the oxyphil cells. They look different. You know, they have a lot more cytoplasm. The cytoplasm is granular and eosinophilic or pink. The nuclei tend to be a little bit smaller, but I think most of you can pretty easily pick out the difference between an oxyphil and a chief cell. I actually saw this on I think one of the practice exam books. They actually have a picture, and they really don't ask you to identify it, but you have to know that the image they're showing you here is a parathyroid gland. And this is what the image is they showed here is of the chief cells. They didn't show you the oxyphil cells. So again, I'm keep on emphasizing this is an image you should know how to recognize. The other curious thing about oxyphil cells, these are the eosinophilic cells, is that we believe they're non-functional, that they do not secrete parahormone or PTH. What they're actually doing, we're not sure. And later in this ISL, we'll go into what actually is in the cell that makes it look pink and granular. And that's probably it for the parathyroid. So any questions about the histology? I always do recommend, if you get a chance, to pull up a histology guide, just kind of flip through it and kind of get the image in your mind so you can recognize it.
I do have one question about the colloid.
I'm sorry, I could barely hear you.
Sorry, I do have one question about the thyroid.
Okay,
the
go
colloid,
ahead.
what deposits it? How is the colloid deposited there? Like, what creates it?
Okay, well, we're actually going to kind of dive into that. I would emphasize right now that for the TBL for Friday, we talked about thyroid. There's all this incredible detail about exactly how thyroid hormone is synthesized. And, at first I thought about it and I go, this is way over the top. But pretty much any physiology book you pull out, they all talk about all this minute detail of, the number of iodines, where it's attached, et cetera, et cetera. So I just can't help but think this is an area ripe for questions. So unfortunately, this is the scourge of medical school, is there are certain details you just have to learn. And I'll go over this verbally. I encourage you to read this carefully in the TBL material, and if necessary, pull out a standard textbook and read their section. It's something that you just have to pick up, and probably for board exam, you're going to need to know some of this. Okay.
Thank you.
I feel sometimes like a broken record, like, I'm sorry, I have to teach you this, but, someone's going to torture you again with this, and some board exam you need to pass is going to include this. So I don't write the boards. Actually, quite a few of the faculty here are involved in writing board type questions. So I think I'm always kind of amazed they have insight into board exams. That's because they're actually writing these questions. So it's kind of scary. Okay, so now we're going to my little mini PowerPoint. And again, a lot of this or all of this material should be within the pre-read, but I like to pull out what I feel are important points and bring them to your attention. So let's start here. Get my pointer there. Okay, so let me give you a few seconds here to look at this. This is pretty straightforward. Hopefully it's straightforward. And yeah. Okay, let's start with someone from group 3. Can you share with us what you think the right answer is? Someone from group 3.
I think that's maybe thyroid tissue, so like an ectopic thyroid gland.
Okay.
Lingual thyroid, maybe.
Okay, thank you. And just anyone else in this, the entire ILS group, does anyone else have a different idea? Anyone else with different take?
I think squamous cells.
Squamous cells? Okay, that's an interesting idea. Anyone else?
Salivary gland.
Salivary gland? Okay. So let's just kind of run through this real fast. The squamous cells is sort of a good place to start, because the whole oral cavity, including the tongue and the lips, they're all covered with squamous mucosa. So those are squamous cells that are non-keratinizing. And so it's quite possible, actually, the surface is covered with squamous cells. But normally squamous cells don't pile up and make a mass like this at the base of the tongue. So I think that's a good idea, but probably not what we're after here. Someone said salivary gland. That is a possibility too. There are all these different minor salivary glands that are actually near the lip, and they're further down in the neck and whatnot. And there could be an ectopic salivary gland, but usually they're not here at the base of the tongue. So someone from the group had mentioned thyroid tissue. That's actually what we're looking for. And this is why, because going back to embryology, This is the embryo here. Here's the developing gut here. And then there's this thyroglossal duct that buds off from the developing GI tract. And at the very end is where the thyroid gland begins. This travels down the midline, migrates down the neck, stops here. And then finally, this is where the thyroid gland grows here. Okay. And so here again is a different cartoon. Here's a lateral view here. So it starts up here. And anywhere along this tract, you can get ectopic thyroid tissue. My understanding is the lingual thyroid here is a fairly common site. Here's another image here of someone has this kind of fleshy, soft lump here right at the base of the tongue in its midline. That's a good probability is ectopic thyroid because embryologically, that's where it started. And you can imagine while it's traveling, it either gets stuck here or some little branch or something gets stuck up here. It comes down. And here's a diagram that shows multiple cases, let's say maybe 20 cases of ectopic thyroid and where each one is. So this doesn't represent one patient. This is a composite of like 20 different patients. And again, they show the lingual thyroid here. And again, notice that they're almost all midline here, even as far down as substernal. And so the most likely answer would be thyroid tissue. I think squamous cells probably is covering the surface, and salivary glands is another possibility. Parathyroid glands, I'd be very surprised if they're up here in the oral cavity. Gastric mucosa is another possibility. Gastric mucosa can kind of appear ectopically almost throughout the GI tract. The mouth would be very unusual, but it's not impossible. Okay, number 2. Let's take about 30 seconds on this. Let me get my timer going in 30 seconds, and we'll get back to this. Okay, let's start with group 10. Group 10. Hopefully group 10 survived the exam and they're here. Can someone from group 10 just shout out what they think the right answer is?
I think this is D, third and fourth pouches for DeGeorge.
Okay, DeGeorge. Okay. And again, I found this photograph of the typical facies of a child with DeGeorge syndrome. In all honesty, I keep on looking at this saying this kid looks perfectly normal to me. The only thing that catches my eye is the space here between the nose and the lip. It looks a little bit wide. And there's also no sort of ridge, groove that you have above the upper lip. So that seems odd. But they point out to all these other findings that, at least in this photograph, don't seem obvious to me. But I think that's often the case in these genetic diseases. They always show pictures of really strange looking kids, but sometimes the changes are very subtle. You really have to look carefully. But getting back to this, I just want to emphasize again, you have been shown DeGeorge syndrome before in different modules. And again, this is a topic that's ripe with questions. And it involves different areas. And so that's why it's going to rear its ugly head over and over again. So this is my summary slide in the pre-read. And, I mentioned the genetics here. That's one way of looking at DeGeorge. I mentioned for us why we're interested in this has to do with embryology. Here's the facies. And just to reiterate again, why the chest x-ray is so important in a pediatric case is that the thymus in a young individual is very large. It's a huge organ. And we know over time it atrophies. And so like in adults, it's very small, almost impossible to find. But in kids, the thymus is huge and it creates this subtle shadow. You can just see the shadow here and probably a little bit over here. And that's normal. That's normal in a kid. However, if you have DeGeorge syndrome, you're often missing a thymus. So you're not going to see this real subtle shadow here or here. So if you ever see an X-ray like that, you need, maybe you're not sure, go find someone else or a radiologist and say, hey, did this kid have a thymus? You know, you might be able to make this fantastic diagnosis here. Okay, but let's get back to what we're talking about. We're talking about the pharyngeal pouches and basically where certain structures arise from the pharyngeal pouches. I always find this to be somewhat of a nightmare because, you know, we don't think in terms of pharyngeal pouches, but embryologically, lots of organisms, especially vertebrates, we all kind of look like this in embryo stage. We have these pharyngeal pouches. And this has all been mapped out, you know, what pouch goes where. And so, again, you know, there are pouches here, 1, 2, 3, 4, and then there are clefts, and then there are arches. Okay, so this is the graph that's in the pre-read. Is kind of confusing, but if you take the time and look at it carefully and follow the colored dots, you can see what's going on. But it's not easy to see in this particular diagram. So you start with the third pouch here, and the ventral part of the pouch, the lower part of the pouch is this pink thing. You come down here, and now this pink thing is bigger, and eventually that will migrate further downward. That becomes the thymus. And the upper part of the third pouch comes down and is also attached to this pink thing. And likewise, when this migrates downward, it pulls that along too here. So that would become the inferior parathyroid. And that's why the inferior parathyroid is dragged down, because it's, you know, at one point part of the same complex as the thymus. Now we go further down here. This is further down, and we have the blue thing here. The dorsal part migrates here. That becomes the superior parathyroid. So when you think about this, is really weird. You know, why would the thing on top, superior, end up below, and the one that's below end up on top is crossing over? But again, the key to understanding this is that it's associated with the developing thymus, which migrates further down. Okay, and this graph's a little bit clearer. So again, here's the third, the dorsal and ventral part. It comes down here. So the bottom part becomes thymus. The top part gets deposited as the inferior parathyroid. The pouch below the upper part migrates a little bit further. It becomes just the superior parathyroid. So again, here's this kind of crossover effect here. And let me go back up here. There's one other thing here. There's the fourth pouch here, this lower part, this yellow dot. That becomes this strange thing called the ultimobranchial parafollicular cells. And that will become the C cells, which we'll get to very quickly. So this is a real challenge to memorize this, but it's not impossible in terms of where the different parathyroid glands come from and which pouch they're associated with. And the reason it fits into DeGeorge again is because the genetic abnormality affects the third and fourth pharyngeal pouches. There we go. So you got the right answer. Okay, 3 is real straightforward. We'll just give you a couple of seconds on this. This is straightforward. Let's try group 7. Group 7, just shout out what you think the right answer is.
Thyroglobulin.
Thyroglobulin, yes, thank you. I think we already mentioned this in the very beginning. That's part of the colloid. The pink thing we refer to as colloid, but it's actually composed of thyroglobulin. It's not mucus, it's not digestive enzymes, calcitonin, no, it's not, and it's not blood. Okay. And thyroglobulin, okay. Now, this one, let me give you at least 30 seconds here. So it's like get my iPhone here working. 30 seconds. Okay, let's go to group one. Group one, this someone shout out what they think the right answer is. Group one.
Yeah, hi. So personally, I did not do the pre-read yet, so I'm just gonna take a nice guess at this one.
Okay,
Let's see. Colloids at so before two. Ooh,
So we're talking about pinocytosis. Where
Yeah.
would you see pinocytosis?
probably I'll go with two, I guess. Do you
Two,
see a
okay.
one or two? I mean, it's coming in from a lumen or a colloid, probably the lumen. I'll go with one or two. Two
One or
answers.
two. Okay. So how about someone else in group one? Maybe someone else had a chance to do the pre-read.
So I was thinking maybe D because pinocytosis happens closer to like the membrane, but I'm not exactly sure.
Okay. Okay. So let's kind of go over this systematically. Again, on H&E, you can't see this kind of detail. You have to look at an electron micrograph to get a better sense. And it's important to keep in mind where exactly the colloid is, because the colloid is over here, this granular gray stuff. And also, if you look at the microvilli, the microvilli are always facing into the colloid. Okay, so that gives you your orientation. This is the apical end, this is the basal end, and this end goes out to the interstitium, and the blood vessels are out here. Okay, so with that orientation, what the thyroid follicular cells do basically is they suck in every iodine molecule that comes by. So the iodine molecules come in the basal end, they get processed, and they kicked out to the colloid, to the thyroglobulin. There's all these chemical processes that attach the iodine onto the L-tyrosine molecule, and it becomes either T3 or T4. And that's all still mixed in with the thyroglobulin. When you're ready and your body needs T3 or T4, you have pinocytosis. It sucks in the thyroglobulin. And remember, we talked about those bubbles you see around the edge of the colloid. And it sucks in the thyroglobulin, forms a vesicle, it merges in with lysosome, and then it breaks down the thyroglobulin to release the T3 and T4, which eventually will come out this end into the bloodstream. And then what's left over is you have some residual thyroglobulin. That gets broken down further. The iodine is recycled and shoved back up here in the colloid. Sometimes the thyroglobulin actually leaks out to the blood, so that can be measured. And then there's residuals of MIT and DIT floating around. So there are things going in and things coming in here and out this direction. It's sort of bidirectional. And so in this case, we're talking about pinocytosis, and it was mentioned they think D is correct. That should be the correct answer because it's on the apical end next to the colloid where you see the microvilli. Okay, and this you'll find either this cartoon or something very similar to it in the pre-read. And if you can understand this summarizes like 5 or 6 slides in this one diagram. So my strategy would be to read the slides that go into this detail about how iodine gets into the slide and how it's organified, how it's put into the thyroid hormone, and read those steps and then come back and see if you understand where it's going on in the diagram of the cell, because things are happening in specific locations. And so just to go over this one more time, real quickly, a little bit more detail. The iodine is out here in the blood. The thyroid gland is picking that up, and they use this item here called the sodium iodine symporter. That transports that iodine and concentrates it into the cell. Then on the other end, there's something called a pendrin and that kicks out the iodine right out here into the edge of the colloid here. And in this area here, there's an enzyme called thyroid peroxidase that first strips off the iodine, so it's actually an ion again, and then it starts to place the iodine molecule on, or the iodine element onto the beginning of the thyroxine or thyroid hormone. It forms all these different combinations. There's one molecule that has just one iodine, some have two iodines, T3 has three iodines, T4 has four iodines attached. And this is all mixed up in thyroglobulin, and they're all in different proportions. When the body needs T3, T4, there's a whole messenger system, and it tells the cell, hey, I need the T3, T4 now. And so then it sucks in the thyroglobulin, mixes it with lysosome, breaks down the thyroglobulin, releases the T3, T4, they come out into the bloodstream, the residual stuff gets recycled, and some parts of it get kicked out to the colloid again. So all these steps, you should have an idea of what these steps are, and again, where are they happening in the cell? What a challenge, huh? But well, unfortunately, I'm not going to give a lecture again in TBL3, but you'll now be asking kind of questions about this. Okay, so here's that, the same EM micrograph. Again, the microvilli gives you a clue that it's the apical side, and that's the answer again, D. So boy, that's a lot of verbiage there for one slide, but there's a lot of detail there. Okay, this one, it looks long, but actually goes quickly. So let me give you about 30 seconds to a minute. Look at this. Okay, I'm assuming you guys are speed readers now. Let's ask group 5. Group 5, can someone just let us know what you think the answer is? If you have to guess, that's okay. Guessing
I was thinking C.
C. TSH levels would drop because of a negative feedback mechanisms to the anterior pituitary and hypothalamus. Okay, how does everyone feel about that? They feel good about that? Okay, I'm getting one thumbs up here. Well, let's just kind of go over this real fast, because I always like to point out why things are wrong. Sometimes learning why it's wrong kind of reinforces ideas. The first thing is we talked about how the main control mechanism is negative feedback. Positive feedback tends to be uncommon in the hormone system. And if you do have positive feedback, sometimes it's pathologic. So here, I think I used a term here somewhere, but there's positive feedback. And so when you read positive feedback, you have to be suspicious, saying, that's uncommon. Is this a pathologic condition? Okay, so I would be suspicious of that right off the bat. This one says there is no feedback mechanism. And I would say you need to be suspicious of that, because there is a high probability every hormone system has some type of feedback system, either positive or negative, more than likely negative. And then over here, TSH levels would rise and fall depending on if the thyroid receptors are saturated or not. My understanding is the TSH levels are strictly determined by how much of the feedback mechanism is getting there. So in other words, if there's not much thyroid hormone in the blood system, the anterior pituitary and hypothalamus detect that, and they go, we need more. There's not enough in the blood system. I could tell that. And so they start producing TSH, because they're trying to tell the thyroid, give me more. And they'll keep on doing that until they get more thyroid hormone. And it has nothing to do with the receptors on the thyroid gland becoming saturated. They really could be saturated, but it's going to keep on producing it until it gets the message that I have enough thyroid hormone in the blood system. So that's not good. So C is the correct answer, and it's the most common finding within the hormone system. And here's the diagram that comes in the pre-read. It just emphasizes that there's negative feedback to both the pituitary gland and to the hypothalamus. Now, one thing that's not mentioned very much, actually in the physiology books that I looked at, is we have a better understanding of how negative feedback works directly on the cells of the anterior pituitary. Oftentimes, we don't know exactly what exactly this negative feedback is to the hypothalamus. Is it something actually in the neuron itself, or is it going to some other cell that's talking to the neuron? Or is there some other receptor somewhere else in the brain that's telling this neuron to make TRH or not? So this is a big sort of, we're not really sure what's going on. So, they always tell you, try and find something good, find something good to say. Well, this is something good to say is like, thank God we don't know this. Otherwise, this is something else you have to memorize, right? Maybe the next generation of medical students will have more knowledge and they have even more to learn. Okay, I don't think anyone's buying that, so I'll stop there. So C is the answer. Okay, a quick question. Let me just give you a few seconds to read this real fast. Okay, so group 9. I don't think I've called them group 9. Can someone just shout out again what they think is the correct answer? Someone from that group? There's a lot of hesitancy here. Okay, maybe everyone's just tired. If I don't say anything, Dr. Hunter will eventually start jabbering again. Okay, so let's just go over this. The first thing you need to ask yourself is, okay, he's circling something here. What is that? So we actually didn't go into detail about this, but this is a C cell. And they're really hard to find on the standard H&E section. I'm sort of asking you here, but on a test, I would not ask you for a practical test question like, is this a C cell or not? The reason being is they look very similar to a follicular cell here. Nuclei are about the same size. There's a little bit more cytoplasm. The only way that I'm pretty sure this is a C cell is that follicular cells form this ring, and they always have colloid in the middle. So here's colloid, and these nuclei circling the colloid, those are follicular cells. This cell is sort of out by itself. It's in the interstitium, and it's not touching any colloid that I could see. So just by deduction, it's sort of like, well, more than likely that's a C cell. To be absolutely sure, you need to do a special stain, which I'll show in the next slide. So this is a C cell. C cells secrete calcitonin. Now, since we have this up here, thyroid. So, okay, thyroid hormone comes from what cells? Anyone just shout out? Where does thyroid hormone come from? Cells in this image.
Is it parietal?
Parietal? No.
Chief cells.
I'm sorry?
Chief cells?
I'm not quite hearing that correctly.
He said chief cells, but
Chief cells? No.
no, this is
that's
thyroid.
parathyroid. This
Right,
is an image of the thyroid.
We're talking about follicular cells, is that
Yeah,
correct?
follicular cells. And that's pretty much.
No one hear me?
Yeah. So pretty much all these cells here in this image, except for maybe that one, these are follicular cells. These are the cells that produce the thyroid hormone. Iodine I'm really not aware of what cells give up iodine. Iodine is a precious commodity in the thyroid. It sucks it in, it doesn't want to give it back to you. Platelets, what cell do platelets come from? This is several modules back.
Rhombocyte.
Karyocytes.
Megakaryocyte.
Megakaryocyte. Yes, yes, I like that. And where do megakaryocytes like to live?
Bone marrow.
Bone marrow. Thank you. Okay, good. You know, all these little tidbits, you know, you have to just kind of fly around your brain rather. Okay, so and megakaryocytes, as the name implies, they're really big cells, and they're also have multi-lobated nuclei. And so they're pretty strange looking cells. I don't see any huge cells here with multi-lobated nuclei. So this is not a megakaryocyte. Megakaryocytes usually live in the bone marrow, but in some cases they can live in the lung. Hypothetically, they could live probably anywhere in the body. I'm sure if I looked at thousands of sections of someone's thyroid, I might find one. But you know, for the most part, they're in the bone marrow and a few in the lung. And thyroid stimulating hormone, where would that come from? Would it come from cells in this image? Thyroid stimulating hormone, or TSH.
Anterior pituitary.
Anterior pituitary, yes, very good. It comes from the pituitary gland. Okay, so all these things you have to keep on juggling in your mind in endocrinology. You know, what's the name of the cell? What does it produce? Where does it go? What does that hormone talk to? What's the second messenger? What's the end product? So the list just goes on and on and on. Okay, and this is in your pre-read. Again, this is another example of more than likely a C cell. I can't be 100% sure, but if you do a special stain for calcitonin, this particular stain will stain it brown. They're really easy to see now. But again, the main point is they're in the interstitium and they're not really physically touching the colloid. That's the biggest clue. Okay, calcitonin from C cells. Okay, this is a kind of trick one. I'll have to give you at least a minute on this. I want you to kind of read this and ponder this. I think we may have some budding surgeons in the group. So. I think my timer went dead on me. Okay, well, I'm assuming it went off. Let's ask group 4. Group 4, would anyone like to volunteer in group 4? What they think the answer may be?
Certainly. I think there should be 4 parathyroid glands. So in this case, one of them is ectopic. So I think A is the correct answer.
A is the correct answer. Okay. Does anyone else have any ideas, or do you agree with Nick on that?
I was thinking that more than one of them could be right. Those 3 parathyroid glands could be fine, and there could be a parathyroid tumor somewhere else in the body.
Okay. I will admit that there are other possibilities, but one is more likely than the others. So I think some of these other answers are possibilities, but they're less common.
They would have assumptions, is what you're saying. So Like Occam's razor, like the most correct without assumptions? Or is it okay to assume there's a tumor somewhere or that there's an ectopic parathyroid gland?
The correct answer to me is what is the more common reason?
Okay.
Okay.
Yeah, then maybe.
So let's kind of go through this. Nick is saying there's probably an ectopic parathyroid because he only found 3, and we normally have 4. And so this person probably is hyperparathyroid, has elevated calcium, so they know there's too much PTH in the body. The question is, where is the PTH coming from? Probably 95 times out of 100 is coming from an abnormal pituitary gland. And so you found 3, you're missing 1, so there's got to be 1 some other place. So you got to go looking for it. Okay. B is there another tumor in the body which is secreting PTH? And I guess hypothetically that's possible, but I haven't searched the literature. There may be 1 or 2 cases probably out in the world, but this would be extremely extreme. This would be reportable. One of the 3 parathyroids is really the tumor, but it's not enlarged. That is a possibility, but again, that would be fairly uncommon. If it's producing symptoms, I don't say if it's producing symptoms or not, but most parathyroid tumors are large, about the size of a quarter at least, let's say. So that's a possibility, but that would be uncommon. And 3 or D would be actually all 3 of the parathyroids you found are actually all secreting excess amounts of parathyroid hormone. And actually, there are cases of patients that have hyperplastic parathyroids, and all the parathyroids are producing way too much because they're being overstimulated. That's kind of a bizarre situation, but it does happen. But the most likely answer would be A. Okay, so let's just talk about ectopic parathyroids. This diagram is a composite. It's not one patient with 50 parathyroid glands. This is like 50 different ectopic parathyroid cases, and they just summarize all the data on this one cartoon. So you kind of get the sense ectopic parathyroids, they can be high, they can be low. Looking at the lateral, they can even be behind the trachea. So you're going to need a good surgeon to carefully dissect as far as they can go to find this ectopic parathyroid. Sometimes when they do a parathyroidectomy, actually in the consent, the patient will have to sign saying, if need be, they can crack my rib cage and go into my mediastinum to look for it. Oftentimes before surgery, they will perform a nuclear scan using a special tracer that's specific for parathyroids or selectively goes to parathyroid glands. And so in this patient, you can see the parathyroid's kind of lighting up. This is not the greatest scan in the world, but here's parathyroid, but here's 1 extra dot here. So that's a good hint that this patient has an ectopic parathyroid, and the surgeon better be ready to crack the chest if they have to. Okay, so the answer would be ectopic parathyroid. I would mention too that I use the example that the surgeon is a female in town. We do have a very good head and neck surgeon who's female, who specializes in parathyroid surgery. And so I would say if you have a parathyroid problem, you're in good shape because we have a great surgeon in town.
Dr. Honda, do you mind if I ask a question about this?
Yeah, go ahead.
So is the issue coming from the fact that the ectopic gland became cancerous, or is the fact that it's an ectopic gland somehow outside of normal regulation? Does that make sense?
I think it's the fact that it's become neoplastic. It's not the fact that it's ectopic. It's the fact that potentially any parathyroid tissue can become neoplastic. And it just so happened it's in the wrong place. And the one that's in the wrong place became neoplastic. So it's quite possible someone's got an ectopic parathyroid in their mediastinum or some other weird place, and it's perfectly fine. We'll never know. It's only when the ectopic one starts producing too much PTH, then we start looking around for it. And I'm trying to remember what was the number. I think here is about 15% of patients undergoing parathyroidectomy for tumor that they actually find out they have ectopic. So maybe that statement you have is it's kind of enticing, that maybe the fact that they are ectopic would make them more at risk for becoming neoplastic. That's an interesting idea. I never thought of it that way. Usually we think about it in very pragmatic ways. It's like, here's a procedure that should take 45 minutes. Now this procedure, because you're looking for an ectopic, could take 3 hours. Okay, let's move on. I'm trying to get through this within an hour, if that's okay with you guys. Number 8, let's just give you a couple seconds here to look at this. Okay, so let me pick on group 6. Hopefully group 6 is still alive, well, and looking at their monitors. Group 6, what do you think the answer may be?
I think it's D, mitochondria.
Mitochondria, okay. What does everyone else think? Think they're on the right track? I'm getting one nod here, okay.
Honestly, I can't see what he's seeing as far as mitochondria, but I would guess they would be there.
No, well, we're looking at a light micrograph.
Yeah.
Okay, and you're not going to see mitochondria at that type of procedure of magnification.
Yeah.
You need electron micrograph. Okay, so the first question is, what are these cells here? What do you want to call these?
Principal cells?
Yeah, principal or chief cells. Okay, they're the ones producing the PTH. And what do you want to call these cells here?
C cells.
C cells? No.
Oxyphil.
C cells are in the thyroid. Okay.
Oxyphil.
Oxyphil, yes, oxyphil cells. So the question is, why are the oxyphil cells, why do they look different? Why do they look pink and granular? So someone said mitochondria, and indeed that's what it is. And if you go to an electron micrograph and look at oxyphil, it's stuffed full of mitochondria. And I'm not sure why, but mitochondria likes to stain pink or red. And again, if you look at this photomicrograph, it's chock full of mitochondria, but I don't see any secretory vesicles. So that fits into what we were saying before, that it's not secreting PTH. Or on the other hand, the principal or chief cells, you can find these dark granules here. It's producing PTH. Okay. So now let me just kind of run through some of these real fast, because I'm trying to get you guys out and let you relax a little bit, eat a good dinner, and then keep on studying. So this is the microscopic view of a gland from the neck. So I'm not even telling you what it is. So far, we've been talking about things in the neck would be thyroid, parathyroid. If you include HDM, we can talk about lymph nodes. Maybe there's some other things in the neck. So the question is this a hyperplastic parathyroid gland? Is it a thyroid gland? Is it a lymph node? Is it normal parathyroid? So everyone's nodding, but I don't know what they're nodding about. Do you think it's D?
Yeah, there's fat present.
There's fat present. Very good. More than likely, if you see fat intermixed in, more than likely you're dealing with a parathyroid gland. Occasionally you can see fat in a lymph node, depending where you pluck it out from. Thyroid gland usually does not have fat in it, and it's not a hyperplastic parathyroid gland because they wouldn't have any fat. The fat would have been replaced with the neoplastic cells. So again, this is sort of summarizing. Now, actually, I cheated. This is what a hyperplastic parathyroid would look like, but I actually used the same piece from Histology Guide. I just picked an section that didn't have any fat, but In a truly hyperplastic parathyroid, the whole parathyroid gland will look like this from one end to the other. If you have colloid forming these circles, you got thyroid. If you got follicles with big and large cells that are dense chromatin, you got a lymph node. Okay, so those are some of the major structures you'll find in the neck. So it's a normal parathyroid gland. Again, the key fact, there's some fat intermixed in there. Okay, now let's get down to some nuts and bolts anatomy. Basically identify what the green arrow is pointing to here. And let me just give you a second, and maybe someone can just shout out what they think the right answer is. So when everyone kind of stare at this.
E.
I'm sorry, someone say D.
Is it E?
E, okay. It's a possibility.
D, D, D.
D.
It's B. Delta.
B.
D as in dog.
D as in dog. Okay, gotcha. Okay. Well, let's just kind of think this out real fast. Here's the thyroid gland here, because we've been talking about the thyroid, right? Not so much the parathyroid. Thyroid here is big. And so coming from the superior aspect, we have an artery. And actually, this artery branches right here. And there's an anterior branch and there's a posterior branch. You can't see the posterior branch. It's just whoever made this diagram didn't show you posterior. You have arteries coming in from the inferior aspect. And again, this branches. Now, this one, they did show, you can see sort of the shadow of the posterior branch, and here's the anterior branch. So sort of like the pancreas again, there's superior, inferior, anterior, posterior. So it's just a matter of looking at this saying, okay, it's coming from the top, it's got to be superior. I can see it on the surface, so it's got to be anterior. So D is the correct answer. Now, since we're talking about this, I've got this thing called the EMA thyroid artery. It's mentioned in the pre-read, but I just want to spend a second talking about that. The EMA artery actually comes from below. EMA means inferior or lower. And a small percent of the population, up to 10%, actually has a thyroid EMA artery. It originates in different places. So I think that's why we don't really emphasize it, because it's not always there. And when it is there, some of them come from the external carotid, some come from the aorta, some come from the subclavian. So it just kind of is all over the place. For the most part, it doesn't have any significance, except in one major case, and that is if you're doing a tracheostomy. You're opening up the patient's neck very quickly because you're trying to insert a trach tube so you can get a vent tube in there. And if the person has the thyroid EMA artery, usually it's right on the anterior surface. And so if you start getting a bleeder, maybe you're dealing with a patient that's happens to have an EMA artery. So you just need to cauterize that or close it up somehow. So that's the EMA. Okay, there we go again. Okay, now this one, let me talk through it, because otherwise I'll torture you folks endlessly about this. Why is the recurrent laryngeal nerve pathway different on the right and left sides? So on the right side, we have this big nerve coming, and then the recurrent comes around. It goes behind the brachiocephalic, and it actually goes behind the thyroid, comes back up here. But on the left side, just let me finish it. The left side, it comes all the way down, and then it goes behind the aorta. It comes down much lower. Then it goes up behind the thyroid. And now, I'm sorry, you had a question?
Oh, no, I thought you asked why it did that, and I was saying evolution.
Evolution, okay.
Yeah, because it slowly crept down as.
Okay.
Like it does that in fish too.
Okay, anyone else have an idea?
In embryological development, we keep the aortic arch number 6,
Okay.
which on the left side, and so it can't go up like it does
Okay.
on the right?
Okay, so it's like evolution, embryology, arches that are disappearing, right? And some that are staying. Okay, I think we're on the right track. So in the pre-read, you'll find this diagram. This is our embryologic arch system, which we have when we're in the embryologic state, but we don't keep these as we mature. And we lose 5 and 6. We actually lose 5 and 6 on both sides. But what happens is 6 on the left side remains as the ductus arteriosus here. And so the ductus arteriosus traps the recurrent laryngeal nerve on the left side. So that's why it's trapped underneath here and remains under the aorta. If we didn't have the ductus, then this would be up here. It'd be under the branch, the remaining 4th branch here. So it has to do with embryology of disappearing arches here. Involves 5 and 6. Now, why do we get so hung up on this embryology? Why do we get so hung up about the recurrent laryngeal nerve, right? So actually, for your budding surgeons, you're concerned about the recurrent laryngeal nerve because you never ever want to cut that. If you cut that nerve, the patient's going to lose control of their vocal cords. They'll either get a really hoarse voice, or they won't. Some rare cases, they won't be able to talk at all, and that is a major loss because every surgeon that operates on the neck knows if they're anywhere near the recurrent laryngeal nerve, or actually the superior laryngeal nerve too, they need to carefully dissect in those areas, identify those nerves, clearly mark them, and stay away from them. So here's a photograph of a surgeon working on the right lobe of the thyroid. You can see these clips. They use these clips to cut off the blood supply when you get a bleeder. It's faster than trying to suture them closed. And during this procedure, he used a probe here to find this wispy little white thing here running deep to the thyroid gland, posterior thyroid. That's the recurrent laryngeal nerve. And this surgeon is going to stay as far away from that as possible because you do not want to cut that. So that's why we make a big deal. Also, nerves tend to follow arteries. And so that's another way they look for it is they can trace the different thyroid arteries, and they know there's a nerve around it someplace, usually deeper to the artery. But the main thing is they use some type of a stimulator that they probe around the neck, and they look for some type of reaction. And so they want to make sure where that is. So again, don't mess with the nerves going to the larynx, the voice box, because you can really injure a patient. So those are the highlights from this ILS. And any burning questions? Okay, I think I finished within an hour. Let me say a few words. A few words about the DSA for tomorrow, and then the TBL for Friday. Okay. First, the TBL for Friday. Again, I want to emphasize there's a lot of details about exactly how iodine and how that gets in to become a thyroxine, all these different steps, the difference between T3, T4, the conversion of T4 to reverse T3. All this sounds like real minutia, but a lot of this has direct application to patient care, of which, a lot of times I allude to it, right off the bat. And some of the other faculty kind of get after me for presenting all this clinical stuff now. But I always like to emphasize the important basic knowledge about the thyroid you need to pick up quickly now. And we'll go over it again when we go into ERS2. We go more into clinical scenarios. But if you can master this now, it'll make ERS2, I shouldn't say easy, but it'll make it more streamlined. Now, for the DSA for tomorrow, it's kind of a hodgepodge. It talks about all these different hormones. Some of the hormones that you've talked about already, I go over some of the GI hormones again. I've looked at your course material. You had some of that in GI already. It's just here, again, because it is a hormone. I think you need to focus your attention on things like ANP and BNP. You'll see 3 or 4 slides on that because I don't think that's discussed anywhere else in the first year curriculum. And that's becoming more of interest, ANP and BNP. And we're not going to talk about that in other TBLs. So this is where you need to pick up that information. The other area that I would spend some more time on would be the pineal gland, because there's more interest in the pineal gland. It's sort of a mysterious thing in the back of the brain, and we always don't know what it does. People that are into the occult are really into the pineal gland. You know, some people call it the third eye. It seems to be involved in sleep. So there's all kind of interesting tidbits, information, pineal gland. So this is time to read up about that. I don't think they're going to talk about pineal gland again. Well, maybe in the neuroscience part, they'll talk about pineal gland. So, and then other things that are mentioned, like erythropoietin, I believe, again, that was mentioned in renal. So you can just scan that real fast. And I'm trying to think what else is in there. But the main thing is ANP, BNP, and pineal gland are the things I would make sure that you read carefully. So that's it. And I'm not sure, I think I mentioned it in the earlier TBL. Be sure and set aside time this weekend to get ahead in your pre-reads for week 2, because week 2 goes by very quickly. There's a test a week from Friday. And there's a lot of stuff we haven't covered that we need to cover. And so the TBL on Monday is going to be a killer. I'm sorry, but we just got to give you a ton of material. The ILS on Wednesday is going to be a killer. There's a lot of material in there. And so if you can kind of start the process on the weekend, you'll get ahead, and you won't kill yourself the night before the test. So with those hints and clues about how to allocate your time, I'll leave you be. Any more questions real fast? Okay, if you have questions, email me. I'll try and get back to you as soon as possible. If not, you have the DSA, and then we'll see you Friday morning.